Welcome back to the deep dive. Today, we are undertaking a pretty deep exploration of the largest and probably the most tireless internal organ in your body, the liver.
Hmm.
Think of it as like the ultimate multitasker, right? The silent workhorse performing, over 500 vital, complex functions every single day, often just running in the background until, well, maybe abruptly, it decides to clock out.
That's absolutely the right way to frame it. I mean, when you look at the sheer volume and the diversity of chemical processes the liver manages, from blood purification to synthesizing key hormones and proteins, it truly functions as the body's central, highly regulated processing hub.
Right.
So our mission today is really to cut through some of that complexity. We want to give you a clear, structural, and clinical understanding of this essential system, and not just focusing on the liver itself, but also its critical partners in digestion and metabolism, so the gallbladder and the pancreas.
Okay.
It's kind of the essential shortcut, if you will, to becoming truly well-informed on hepatic and biliary disorders.
Before we even get into the nuts and bolts of anatomy, we really have to talk about the liver's absolute superpower. It's this quality that sets it apart from pretty much every other organ in the body. It's a master of self-repair.
It is. It's unparalleled in its regenerative capacity. I mean, unlike heart or brain tissue, which suffer permanent damage, if you remove, say, up to 2/3 of a healthy liver.
2/3.
Yeah, the remaining cells can proliferate really rapidly, growing the organ back to its original weight within just a matter of weeks.
That degree of rapid regrowth is just astounding. Does the research point to specific signals? Like, what kicks off that rapid regeneration after such massive tissue loss?
Yeah, we know the process is it's tightly regulated. There are complex cytokine and growth factor signals involved, primarily things related to interleukin-6 and HGF, hepatocyte growth factor.
Okay.
But the takeaway here clinically is huge.
Yeah.
This is why partial liver transplants from living donors are actually possible. If a living person donates, say, their right lobe, both the donor's remaining bit and the recipient's new segment will regenerate. They grow to full functional size, usually within months. It seems to be a mechanism driven by the mass requirement. The body senses the functional deficit, basically, and demands regrowth until the original size is restored.
It's phenomenal, but like you said, it highlights this fundamental paradox we need to explore later.
Yeah.
If it can regenerate so incredibly well, why do we ever get irreversible scarring like cirrhosis?
Exactly. That's the key question in chronic disease.
But sticking to its roles for now, you mentioned its simultaneous jobs as a purification plant and a factory.
Exactly. And these two functions can often seem contradictory, right? It's a purification plant because it filters nearly everything you absorb, drugs, alcohol, environmental toxins, clearing the blood before it reaches the rest of your circulation. But it's also a factory, just ceaselessly producing vital blood proteins like albumin, clotting factors, cholesterol, and of course that digestive fluid we call bile. It has to manage the cleanup while simultaneously running this high-volume manufacturing operation. It's quite a balancing act.
Okay, let's ground ourselves geographically first. Where exactly is this, 3-pound, triangle-shaped workhorse located?
So it sits primarily in the upper right quadrant of your abdomen, tucked up high, kind of protected by the rib cage right underneath the diaphragm.
Okay.
Structurally, anatomy is typically divided into 4 lobes.
Yeah.
You've got the massive right lobe, the smaller left lobe, and then 2 smaller structures you see more on the posterior side, the caudate and quadrate lobes.
But thinking clinically, when a surgeon looks at the liver, especially if they're planning a resection or maybe a transplant, they don't really think about those 4 lobes in the same way, do they? They're thinking about the functional flow.
Correct. Yeah, the anatomical lobes are really secondary to the functional division. Clinicians, especially surgeons, divide the liver into 8 segments. They're called Kuno segments.
Kuno segments, okay.
And these segments are defined entirely by the intricate branching patterns of that dual blood supply we mentioned, and also the biliary drainage system. This functional map is absolutely essential because it allows surgeons to, say, remove disease sections without compromising the remaining healthy vascularized segments. They follow the plumbing.
Right, follow the plumbing. Now let's zoom in microscopically because this is really where the action happens and often where disease begins. What's the fundamental unit of liver function down at that level?
Okay, so the liver's architecture is built around literally thousands of these tiny hexagonal structures called hepatic lobules.
Hexagonal.
Yeah, these are the functional units. And at the corners of each hexagon, you find what are called the portal triads. That's where the blood flows in. Now, the majority of the liver volume, maybe 80%, is occupied by the main workhorse cell, the hepatocyte.
The hepatocyte. So that handles the synthesizing, the metabolic stuff, the endocrine work. But how does the blood actually mix and get processed within that lobule structure?
Right, so the blood flows from those portal triads at the corners inward through these specialized capillaries called sinusoids.
Sinusoids.
And this is critical. The sinusoids are lined with endothelial cells, but they're highly permeable. They have gaps. This allows the hepatocytes direct access to everything circulating in the blood.
Okay.
Also lining these sinusoids are two other essential cell types we absolutely have to remember when we talk about disease.
Mm-hmm.
The Kupffer cells and the stellate cells.
Okay. What are their roles? Kupffer and stellate?
So Kupffer cells are basically the liver's resident macrophages.
Mm.
Think of them as the immune system's cleanup crew. They're constantly monitoring the blood coming from the GI tract, clearing out bacteria, pathogens, old cell debris.
Right.
Stellate cells, on the other hand, are kind of the silent partners in disease. When the liver's healthy, they mostly just store vitamin A.
Yeah.
But when inflammation becomes chronic, these stellate cells become activated. And they are the primary source of the collagen that produces fibrosis and eventually cirrhosis. If you understand stellate cell activation, you really understand why chronic injury leads to irreversible scarring.
That makes the whole plumbing system even more complex. Okay, let's address that dual blood supply directly. Why does the liver need two different inputs? I mean, every other organ seems pretty happy with just one artery.
It's absolutely necessary because the liver is the gatekeeper, right, for everything absorbed from your digestive system. It needs its own nutritive supply just to survive, like any organ, but needs a much, much larger functional supply to actually execute its filtering and balancing duties.
Okay, lay out those two sources for us again.
So source number one is the hepatic artery.
Yeah.
This is the nutritive supply. It carries highly oxygenated arterial blood, but it only accounts for maybe 20% to 25% of the liver's total blood flow.
Just enough to keep the lights on for the liver cells themselves.
Exactly. Just enough to ensure the hepatocytes stay healthy and oxygenated enough to do their massive job.
And the massive route, the one carrying, the contents of dinner and everything else absorbed, that's the hepatic portal vein.
Correct. The portal vein delivers the huge functional load. We're talking 75% to 80% of the blood volume reaching the liver. Now, this blood is deoxygenated because it's already passed through the capillaries of the stomach, the intestines, the pancreas, and the spleen.
Right.
But the content is what matters. It's rich in every nutrient, every drug, every potential toxin, every waste product absorbed across the GI tract. The liver absolutely has to process all of this before releasing the cleaned, compositionally balanced blood back into the general circulation.
How does it get back out then?
It collects in the hepatic veins, which then drain directly into the inferior vena cava, the body's main vein, returning blood to the heart.
So the liver isn't just filtering blood, it's literally vetting everything that enters the main systemic circulation after you've eaten or taken a pill.
Wow. It is the ultimate processing checkpoint.
Yeah.
Absolutely. And one of the most visible outputs of this checkpoint function is its exocrine role, producing bile.
The liver as a digestive juicer. It's kind of hard to fathom the continuous production volume.
Hepatocytes are incredibly busy. They secrete somewhere between 800 and 1,000 milliliters, so nearly a liter of bile every single day.
A liter a day.
Yeah. And bile is this essential yellow-brown or sometimes yellow-green alkaline solution. Its pH is around 7.6 to 8.6. And that alkalinity is important, actually, because it helps neutralize the highly acidic stuff, the chyme, coming from the stomach once it reaches the small intestine.
Okay. We know bile helps us digest fats, but what's the exact mechanism there, and what is bile actually made of?
Right. So bile is mostly water, but it contains these critical active components, bile salts and phospholipids. Along with those, you find cholesterol, electrolytes, and waste products like bilirubin that the liver is trying to get rid of. The active process for fat digestion is called emulsification.
Let's use that dish soap analogy here. I think it's the best way to really visualize it.
Absolutely, it's perfect. Think about eating a meal that's heavy in fats, say triglycerides, like a buttery pastry or something fried. These large lipid globules are hydrophobic, right? They hate water, so they clump together, minimizing their surface area. Now, digestive enzymes, called lipases, can only attack the surface of these clumps.
Okay.
Bile salts and phospholipids are special molecules. They're amphipathic. That means they have both a water-loving end and a fat-loving end. They surround these large fat globules, kind of like soap molecules, and break them down into many, many tiny fragments, often less than 1 micrometer in diameter.
So tiny droplets.
Tiny droplets. This dramatically increases the total surface area available. allowing the lipases to access and break down the fats much more rapidly and efficiently, making absorption possible. Without bile, fats would largely just pass right through your digestive system undigested. You wouldn't absorb them well at all.
Okay, moving from the structural plumbing to the actual operational core of the liver, let's start with its role as the master regulator of energy. Glucose, homeostasis. I
Yeah.
mean, the liver maintains remarkably constant blood sugar levels, which seems like a massive regulatory feat.
It really is. It's the central switchboard for energy management in the body.
Mm-hmm.
So when your blood glucose is high, say right after a meal,
Mm-hmm.
the liver efficiently removes that excess sugar from the blood and stores it as an easily accessible polymer called glycogen. That process is glycogenesis,
Storing it away.
storing it away. But conversely, when you fast or overnight while you sleep, your brain still needs a constant supply of glucose. So the liver breaks down that stored glycogen, that's glycogenolysis. And if the fast continues and glycogen runs low, it can even create new glucose from non-carbohydrate sources like amino acids or lactate. That's gluconeogenesis.
Wow, making new sugar.
Making new sugar. It's constantly performing this really delicate balancing act to make sure your energy supply, especially for the brain, never drops too low.
That system sounds perfectly optimized for, periods of feast and famine like our ancestors might have experienced. But in our modern context of chronic overnutrition, that optimization starts to break down, doesn't it? Leading us towards metabolic disease.
This is a huge clinical problem right now. It links hepatic function directly to conditions like type 2 diabetes and MASLD, metabolic dysfunction-associated steatotic liver disease. The breakdown happens because of something called selective insulin resistance.
Selective insulin resistance. Okay, what does that mean?
So insulin normally has two key messages for the liver. First, stop producing glucose, we have enough. And second, start storing energy, particularly as fat, lipogenesis.
Okay, two signals.
Two signals. Now, in metabolic dysfunction, the liver becomes resistant to that first message. Insulin loses its ability to suppress glucose output. So the liver just keeps pumping out sugar even when blood sugar is already high.
Ignoring the stop signal.
Ignoring the stop signal.
Mm-hmm.
However, and this is the crucial selective part, the liver retains its sensitivity to the second signal, the fat-storing signal, lipogenesis.
Oh, wow.
So you get this situation where the factory keeps manufacturing sugar it shouldn't, while simultaneously being forced by insulin to store more and more fat.
Mm-hmm.
This leads to that rapid buildup of triglycerides within the hepatocytes themselves.
So it's selectively ignoring the beneficial stop sugar message while actually hyper-responding to the store fat signal? That perfectly explains the direct link to MASLD, the fatty liver disease.
Precisely. That fat buildup is the initial stage of MASLD, driven largely by this dysfunctional relationship with insulin in the context of chronic caloric excess.
Okay. Beyond glucose, the liver is the factory floor for other vital compounds. Let's look at its role in protein and cholesterol synthesis.
Right. It synthesizes the vast majority of the proteins that circulate in your bloodstream. The most abundant of these by far is albumin. Albumin acts like a biological sponge. It's absolutely essential for maintaining what we call onconic pressure. That's the osmotic pressure exerted by proteins, which basically keeps fluid inside the blood vessels.
And when albumin levels drop, maybe due to liver failure, you see the consequences pretty visibly, don't you?
Oh, absolutely. Low albumin means that onconic pressure is reduced. Fluid is no longer effectively held within the blood vessels, and it starts to leak out into the tissues. This leads directly to swelling, or peripheral edema, especially in the legs and ankles. And critically, it leads to the accumulation of fluid in the abdomen, which we call ascites.
Right, ascites.
That's a really telltale sign of chronic synthetic failure of the liver.
And let's not forget the crucial link between the liver and preventing, catastrophic bleeding.
Yes, the liver is the sole manufacturer of most of your clotting factors, proteins like prothrombin and fibrinogen, which are absolutely essential components of the coagulation cascade, the process that forms blood clots. It also processes vitamin K, which is required for several of these clotting factors to become active and functional. So if the liver is compromised, measuring the prothrombin time, or PT, becomes an essential indicator of how poorly that factory is performing its job. A longer PT means slower clotting.
Got it. And what about cholesterol management? Cholesterol gets such a bad rap sometimes.
It does, but the liver is the hub for it. It manufactures about half of the body's total cholesterol, and while high levels are linked to heart disease, cholesterol itself is structurally vital. The liver uses it for building cell membranes, for synthesizing essential steroid hormones like estrogen, progesterone, testosterone, and crucially for converting a lot of it into bile acids, which we need for digestion. So it's really a key regulatory center for circulating lipids.
Okay, moving from the factory floor to the purification plant, detoxification. This is the role most people instantly recognize when they think of the liver. How does it manage to neutralize so many different potentially harmful substances?
It employs this really sophisticated two-phase chemical process. In phase one, enzymes, particularly the cytochrome P450 CRISPR,
The P450s, yeah.
right, they modify the toxins or drugs, often through oxidation or similar reactions, making them slightly more water-soluble, or maybe just setting them up chemically for the next step. Then, in phase two, the liver performs conjugation.
Conjugation.
It attaches another molecule like glutathione or sulfate or glucuronide to the substance. This attachment does two things. It usually makes the toxin highly water-soluble, and it makes it chemically inactive. Now it's ready for excretion, either out through the bile, into the feces, or into the blood to be filtered out by the kidneys into urine.
So it chemically tags these toxins for safe disposal.
Precisely. That's exactly what it's doing. This is how it handles alcohol, for example, turning it efficiently into acetate, which is relatively non-toxic and can be used for energy. This dual-phase system handles everything from environmental pollutants to pharmaceutical medications, sometimes activating a prodrug so it can work, but more often deactivating a drug's effects before it builds up to harmful levels in your system.
And one of its most essential waste disposal tasks, which you hinted at, is converting ammonia. This seems fundamental to understanding a major neurological complication we'll discuss later.
Absolutely critical. Ammonia is a highly poisonous neurotoxin. It's a natural byproduct generated constantly from protein and amino acid metabolism, especially by bacteria living in your gut. The liver runs the urea cycle.
The urea cycle.
This is a complex biochemical pathway that efficiently converts this hazardous ammonia into inert, non-toxic urea. Urea is then safely transported in the blood to the kidneys and excreted in urine. If the liver fails, ammonia levels rise rapidly in the blood, and that leads to neurological catastrophe.
Okay. Finally, let's detail bilirubin clearance. This is the mechanism, or the failure of it, that leads to that most visible sign of liver distress, jaundice.
Right. Bilirubin is the yellow pigment that results from the normal breakdown of aged red blood cells and their hemoglobin. The liver takes this unprocessed or unconjugated bilirubin from the blood, chemically processes it, it conjugates it, attaches glucuronide, and then actively excretes this conjugated bilirubin into the bile.
Okay.
So failure to either process or excrete bilirubin, perhaps due to hepatocyte injury or maybe a physical obstruction blocking the bile ducts, causes the pigment to back up into the bloodstream. That results in jaundice, the hallmark yellowing of the skin, the mucous membranes, and the whites of the eyes.
Okay, so given the intense, continuous nature of the liver's work, when it's subjected to chronic, persistent damage, whether that's from alcohol, a virus, maybe excessive fat buildup, it seems to follow a predictable, kind of slow path towards structural failure. This progression usually happens over months or even years, right?
It's definitely a continuum, yeah. And understanding these four general stages is really crucial for diagnosis and thinking about treatment. Stage one is simply inflammation. The body's initial response to any injury. This is often reversible if the underlying cause, the insult, is removed. But if it isn't, the inflammation becomes chronic.
And that chronic inflammation then activates the liver's scar-forming mechanism involving those cells you mentioned earlier.
Exactly. That leads to stage two. Fibrosis. Persistent injury activates those stellate cells we talked about, living in the sinusoids. They lose their vitamin A storage function and transform into these myofibroblast-like cells. And their job then becomes laying down excessive amounts of collagen and other extracellular matrix proteins. This gradual stiffening process is fibrosis. Scar tissue is forming.
And if the damage just keeps going relentlessly, we arrive at stage three. Cirrhosis.
Cirrhosis is really the tipping point. It represents severe, extensive, and largely irreversible scarring. The normal liver architecture, those neat hexagonal lobules, gets completely distorted. It's replaced by regenerative nodules of hepatocytes surrounded by thick bands of fibrous scar tissue.
So the structure is wrecked.
The structure is wrecked. Blood flow through the organ is severely impaired because of the scarring, and the functional capacity of the remaining hepatocytes just drops dramatically. Once cirrhosis is established, the structural damage is essentially permanent. Stage 4, which is end-stage liver disease, or ESLD, isn't really a distinct pathological stage. It's more the clinical manifestation of cirrhosis that's so advanced the liver simply can no longer sustain life without intervention, usually transplantation.
It seems vital to contrast this long, slow burn of chronic failure with acute liver failure, That's a completely different beast, isn't it?
Oh, totally different. Acute liver failure is a medical emergency. It happens rapidly over just days or weeks. It often begins with massive necrosis, sudden widespread death of liver cells, and a very rapid onset of inflammation.
Yeah.
The most common causes, at least in the developed world, are usually drug-induced, particularly intentional or sometimes accidental overdose of acetaminophen or paracetamol.
Right.
Other causes can include severe, uncontrolled acute viral hepatitis, certain toxins like poisonous mushrooms, or rare metabolic conditions. But the key is the patient basically skips those slow stages of fibrosis and cirrhosis and just crashes very quickly.
Okay. Now let's detail the major causes of that chronic damage, beginning with alcohol-related liver disease, or ARLD. It remains a massive public health issue.
Yeah, absolutely. ARLD typically manifests in 3 stages, which can overlap. Stage 1 is alcoholic fatty liver, or steatosis. This is incredibly common. You see it in up to 90% of individuals who drink heavily on a regular basis.
90%.
Yeah. The liver basically prioritizes processing the alcohol over processing fats, leading to fat accumulation in the hepatocytes. The good news here is that if alcohol is completely stopped, this stage is often fully reversible, sometimes within just a few weeks.
But if the heavy drinking continues, the inflammation starts to escalate.
That brings us to stadium 2, alcoholic hepatitis. This is an inflammatory stage. It can range from being quite mild and maybe asymptomatic to being severe, life-threatening inflammation requiring immediate hospitalization. Symptoms often include fever, jaundice, fatigue, and abdominal pain. Persistent, severe inflammation then inevitably leads to the final irreversible stage, alcohol-related cirrhosis. And once you have cirrhosis, the risk of liver cancer and death goes up dramatically.
The other major cause of chronic damage globally is viral hepatitis. Let's distinguish between those acute self-resolving infections and the ones that pose a chronic threat.
Right. So hepatitis A and hepatitis E are generally acute infections. They're transmitted primarily via the fecal-oral route, usually through contaminated food, water, or just poor hygiene. Hepatitis A is pretty much endemic worldwide. Hepatitis E is often linked to things like undercooked pork or contaminated shellfish, especially in certain regions.
Okay.
While they can cause pretty severe illness with those classic symptoms, nausea, vomiting, jaundice, fatigue, they usually clear spontaneously. Your immune system handles it. There's no specific antiviral treatment needed, and the patient typically recovers fully without long-term liver damage.
The real danger of developing chronic disease lies with hepatitis B, C, and D.
Exactly. These are primarily blood-borne viruses. Hepatitis C used to be the most damaging historically, transmitted mainly through infected blood, often via shared needles among IV drug users, or historically through contaminated blood transfusions before effective screening became routine in the early 90s.
Right.
The major triumph here, though, is medical. We now have modern direct-acting antiviral medications, DAAs, that can cure hepatitis C in over 95% of patients.
Cure it completely.
Cure it completely, eliminate the virus, usually within just 2 or 3 months of treatment. This halts the progression to cirrhosis and dramatically reduces liver cancer risk. It's been a revolution in hepatology.
That's incredible progress. What about hepatitis B?
So hepatitis B, HBV, is also transmissible through blood, but also through semen and other body fluids. So mother-to-child transmission during birth is common in endemic areas, as is sexual contact. Unlike C, HBV can be effectively prevented with a highly effective vaccine, which is part of routine childhood immunization now in many countries.
Okay.
While we can't fully cure chronic B infection in the same way we cure C, the virus tends to persist in the DNA of liver cells. We do have very effective antiviral drugs. These can suppress viral replication indefinitely, keeping the virus levels extremely low, preventing cirrhosis and liver cancer in most patients who take the medication consistently long-term.
And hepatitis D is the really unique parasite virus, needing B to survive.
Yeah, it's unique because hepatitis D, HDV, is what we call a defective virus. It requires the presence of the hepatitis B surface antigen to replicate. So a patient either gets co-infected, meaning they get B and D at the same time, or, more commonly, they get superinfected, which means they already have chronic hepatitis B and then acquire hepatitis D on top of it.
And that's worse.
Much worse. HDV significantly accelerates the progression of liver disease and increases the risk of developing cirrhosis much faster compared to having hepatitis B infection alone. The best protection against D, therefore, is actually getting the hepatitis B vaccine. If you can't get B, you can't get D.
Right, that makes sense. Okay, that brings us to what you mentioned is the fastest growing cause of chronic liver disease globally now. Metabolic dysfunction-associated steatotic liver disease, or MSLDD.
Yeah, this is truly a lifestyle disease. It's inextricably linked to the global epidemics of obesity, type 2 diabetes, high blood lipids, dyslipidemia, and hypertension, basically.
Right.
All the components of what we call metabolic syndrome. It starts simply with steatosis. That's just fatty accumulation in the liver, which itself may not cause any symptoms for a long time.
But if that fat buildup starts to trigger inflammation, then the danger really escalates.
That's the key transition. When simple steatosis progresses to include inflammation and evidence of hepatocyte injury, like ballooning degeneration of the cells, it becomes metabolic dysfunction-associated steatohepatitis, or AMASH. The acronym used to be NASH.
Right, MASH now.
AMASH. Once AMASH is present, the risk of developing significant fibrosis and progressing all the way to full cirrhosis is quite high. And currently, MS-LD-MASH is projected to become the leading indication for liver transplantation in many Western countries within the next decade, surpassing both hepatitis C, because we can cure it, and ARLD.
Wow, overtaking alcohol and Hep C. Finally, we should probably mention a few other causes, maybe less common overall, but still critical in differential diagnosis.
Definitely. We have autoimmune diseases, where the body's own immune system mistakenly attacks liver components. In autoimmune hepatitis, it attacks the hepatocytes themselves. In primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC, the immune system targets the bile ducts.
Okay.
Then there are important genetic disorders. For example, Wilson disease is a problem with copper metabolism, leading to toxic copper accumulation in the liver and also the brain. Hereditary hemochromatosis causes excessive iron buildup in the liver and other organs, leading to oxidative damage and fibrosis.
And identifying those genetic causes early is key.
Absolutely critical. Because for many of them, like Wilson disease or hemochromatosis, we have effective lifelong treatments like chelation therapy to remove copper or regular phlebotomy, blood removal, to get rid of excess iron. If caught early, these treatments can prevent the progression to end-stage liver disease entirely.
It's striking how efficient the liver is, often masking chronic disease for years. As we noted, early symptoms are often really vague, just fatigue, maybe some loss of appetite, non-specific abdominal discomfort. But when the synthetic or the excretory functions are truly impaired, the body starts sending out much more specific, often life-threatening warning signals.
Yeah, let's start with the most obvious signal, the one people recognize: jaundice, caused by that bilirubin accumulation we discussed. This means the liver's ability to process and excrete bile pigments has failed, either because the hepatocytes aren't working properly or because there's a physical blockage in the bile ducts.
Right.
And this often results in that characteristic dark, almost tea-colored urine as the kidneys try their best to excrete the excess bilirubin floating in the blood. And conversely, you often see light or clay-colored stools because the bile pigments aren't reaching the intestine to give feces their normal brown color.
Okay. Now, arguably the most dramatic and severe consequence of advanced cirrhosis is the development of portal hypertension. This seems like the central structural failure that drives many of the major dangerous complications.
It absolutely is. Portal hypertension means the pressure within the portal vein system. Remember, that large functional blood supply entering the liver becomes pathologically high. It gets high because the cirrhotic scarring inside the liver acts like a dam, physically blocking the normal, easy flow of blood through the sinusoids.
So the blood backs up.
The blood backs up. It has to find alternative routes, detours, around the blocked liver to get back to the heart.
And these alternative routes lead directly to those dangerous complications, primarily ascites and varices.
Exactly. Ascites, which is the accumulation of fluid in the peritoneal cavity, the abdominal space, is caused by this combination.
Yeah.
You have the high pressure from portal hypertension literally forcing fluid out of the capillaries in the gut.
Pushing fluid out.
Pushing it out. And at the same time, the failing liver isn't producing enough albumin, that sponge protein. So there's nothing to effectively draw that fluid back into the blood vessels. The fluid just leaks out and accumulates, causing that abdominal distension, discomfort, and sometimes breathing problems.
Okay, that's ascites. But far more immediately life-threatening, you mentioned, is the risk of esophageal varices.
Yes. Varices are incredibly dangerous.
Explain what they are. Why are they so dangerous?
So when the blood backs up due to portal hypertension, it tries to bypass the liver via these collateral veins, these detours. These veins are usually quite small, but they swell up dramatically under the high pressure to handle the increased blood volume. This happens particularly in the delicate tissues lining the lower esophagus. These swollen, fragile, thin-walled veins are called varices. They're like varicose veins, but in a much more dangerous location. If the pressure gets too high, or if there's irritation, they can rupture. And when they rupture, they cause a massive, often catastrophic, gastrointestinal hemorrhage. Bleeding varices are a leading cause of death in patients with advanced cirrhosis, requiring urgent, often life-saving endoscopic intervention to stop the bleeding.
Terrifying. Another critical clinical sign is when the filter function fails, specifically the ammonia clearance, and the brain is affected. Let's reconnect the dots on how that ammonia toxicity leads to hepatic encephalopathy, or HE.
Right. So when the liver's urea cycle fails because of severe damage, that toxic ammonia, which is constantly being produced in the gut, isn't converted to urea. It builds up in the bloodstream, crosses the blood-brain barrier, which it normally wouldn't do in high amounts, and enters the brain.
And it messes with the brain chemistry.
It does. Ammonia disrupts normal neurotransmission and causes swelling of the astrocyte cells, which are important support cells in the brain. The clinical picture of DOG is quite striking.
Yeah.
It manifests as altered mental status. This can range from subtle things like confusion, impaired concentration, changes in personality or sleep disturbances, all the way to deep stupor and coma in severe cases.
And there's that unique physical sign we sometimes see.
Yes, absterixis. It's often called the liver flap. This is an involuntary tremor or flapping movement that you see when the patient tries to hold their arms outstretched with their wrists extended, like stopping traffic. Their hands will flap down involuntarily. It's a classic physical sign of advancing HE.
How is he treated then?
Clinically, treating HE focuses on reducing the ammonia load in the body. The mainstays are medications like Laxalose, which is a laxative that also traps ammonia in the colon and helps flush it out, and also rifaximin, which is a non-absorbable antibiotic that works by reducing the amount of ammonia-producing bacteria living in the gut. So the treatment is really focused on reducing the source and absorption of ammonia, not just treating the brain symptom directly.
Okay. To monitor this whole complex picture, doctors rely heavily on a set of blood tests collectively called liver function tests, or LFTs, which, as we sort of established, don't test function perfectly, but monitor two separate things: liver cell injury and the liver synthetic capacity.
Right. Understanding LFTs is paramount, even though the name is a bit of a misnomer. For hepatocellular injury, or necrosis, meaning liver cells are dying, we primarily look at the levels of two enzymes: alanine transaminase, ALT, and aspartate aminotransferase, AST.
ALT and AST.
When liver cells die, they leak these enzymes into the bloodstream. Elevated ALT is considered relatively specific to liver damage, as it's found mostly in hepatocytes.
Yeah.
AST is a bit less specific. High levels can also be released from injured heart muscle, skeletal muscle, or even kidney cells.
But the ratio of AST to ALT can give us a critical diagnostic hint, especially when thinking about alcohol use, right?
It absolutely can. In alcohol-related liver disease, there's often a characteristic pattern where the AST level is typically at least twice as high as the ALT level, so an AST-ALT ratio greater than 2.
Why that specific ratio in alcohol damage?
Well, it's thought to be due to a couple factors. Partly the type of damage alcohol causes, which might preferentially release AST from the mitochondria within the liver cells, but also chronic alcohol misuse often leads to a deficiency in vitamin B6. And vitamin B6 is an essential cofactor needed for the optimal synthesis and activity of the ALT enzyme. So in alcoholics, the ALT level might be artificially suppressed relative to the AST level, contributing to that high ratio.
Interesting. Okay, now for the markers of synthetic and excretory function, the tests that really tell us if the factory is still operational and if the plumbing is clear.
Right. Here we monitor bilirubin. High levels indicate poor excretion, as we discussed with jaundice.
Right.
But most importantly, for synthetic function, we monitor albumin and the prothrombin time, PT, often reported as the INR, International Normalized Ratio.
Okay.
Because albumin has a relatively long half-life in the blood, about 20 days, a significantly decreased albumin level is a key indicator of a long-standing chronic synthetic failure, like established cirrhosis. The factory hasn't been keeping up for a while.
In the PTINR.
The PT measures how quickly your blood clots, which depends directly on those liver-produced clotting factors. These clotting factors have much shorter half-lives, some only hours long. Therefore, a rapidly prolonged PTNR is a very sensitive indicator of acute liver failure, or perhaps a severe acute decompensation of chronic disease. It means the factory's production line has suddenly fallen way behind demand right now.
That makes sense. Are there other blood markers that help differentiate between damage to the liver cells themselves versus a blockage in the bile ducts?
Yes. There are enzymes like alkaline phosphatase, ALP, and gamma-glutamyl transpeptidase, TGT. These enzymes are associated more with the cells lining the bile ducts.
Okay.
So when bile flow is obstructed, a process we call cholestasis, these enzyme levels often rise significantly. If you see both GGT and ALP elevated, especially ALP, it strongly suggests a hepatobiliary problem, maybe a gallstone blocking a duct or an autoimmune disease affecting the ducts like PBC or PSC. GGT can be elevated by alcohol or certain drugs too, so it's less specific on its own, but useful in combination.
Got it. And then beyond blood tests to actually see the damage.
Right, to truly assess the physical damage, we rely heavily on imaging. Abdominal ultrasound is often the first step. CT or MRI scans can give more detailed pictures of the liver's shape, size, texture, look for masses, and assess for signs of cirrhosis or portal hypertension. And increasingly, we're using non-invasive tools like elastography, things like fibroscan, which use ultrasound waves to measure liver stiffness. This gives a good estimate of fibrosis severity, often helping us avoid the need for an invasive liver biopsy to confirm chronic liver disease or cirrhosis.
As crucial as the liver is, it's really only one part of this upper GI digestive team. The whole process of digestion relies absolutely on the efficient partnership between the liver, the gallbladder right next to it, and the pancreas tucked behind the stomach. Let's start with the gallbladder, the little storage unit.
Yeah, the gallbladder's function is elegantly simple, really. It just stores and, importantly, concentrates the bile that's constantly being produced by the liver.
So it makes it stronger bile.
Exactly, by absorbing water. Then, when a meal, particularly one high in fat, hits the duodenum, that first part of the small intestine just after the stomach, a hormone called cholecystokinin, or CCK, gets released from the intestinal wall. CCK travels through the blood and signals the gallbladder to contract strongly, squirting that concentrated bile out through the cystic duct, down the common bile duct, and into the duodenum to mix with the food.
Okay. But when that concentrated bile starts to crystallize, we get the most common disorder associated with gallbladder. Gallstones, or the medical term, cholelithiasis.
Right. Gallstones are basically crystalline deposits. They're typically made of either cholesterol, that's the vast majority in Western countries, or bilirubin pigment, which is more common in certain other conditions. They often remain silent, meaning they sit in the gallbladder, causing no symptoms at all, sometimes for years. The problems start when they migrate and cause an obstruction.
An obstruction is what generates those really intense symptoms people describe.
Precisely. If a stone manages to block the cystic duct, which is the narrow tube leading out of the gallbladder itself, the bile backs up inside the gallbladder. This causes irritation, inflammation, and distension. That's cholecystitis, inflammation of the gallbladder.
And that hurts a lot.
Oh, yeah. It typically presents as sudden, often severe, steady pain in the right upper quadrant of the abdomen, under the ribs. It can sometimes radiate around to the back or shoulder blade. It's often accompanied by nausea, vomiting, and frequently a fever, indicating infection setting in behind the blockage.
Okay, that's blocking the gallbladder's exit.
Yeah.
What if a stone moves further down and blocks the main pipe, the common bile duct? You called that cholelithiasis.
Right. If a stone passes out of the cystic duct and gets lodged in the common bile duct, the main channel that carries bile from both the liver and the gallbladder down to the intestine, that blockage is generally much more serious.
Why is a common bile duct block considered more dangerous?
Because now it's blocking the drainage pathway from both the gallbladder and the liver itself. This can lead to immediate jaundice because bile can't get out of the liver. You'll see dark urine again. And there's a high risk of serious ascending infection called cholangitis, which can be life-threatening. It usually requires urgent intervention, either surgically or endoscopically with ERCP, to remove the stone and relieve the blockage and allow drainage. And importantly, a stone stuck down there can also irritate and block the nearby pancreatic duct, potentially causing severe pancreatitis, which brings us to the pancreas.
Before we jump to the pancreas, let's quickly recap who is most susceptible to getting these gallstones in the first place.
Yeah, the classic risk factors are often summarized by the mnemonic, the 4 Fs. Female, 40, meaning middle age or older. Fertile, related to estrogen exposure during reproductive years. And fat, obesity or high lipid levels. Additionally, things like rapid weight loss, like after bariatric surgery, certain ethnic groups, like Native Americans in the U.S. who have very high rates, and having a strong family history of gallstones all significantly increase the likelihood of stone formation.
Got it. Okay, now let's talk about the pancreas. The liver gives us the emulsifier, bile. The pancreas seems to provide the heavy-duty digestive enzymes and also the essential buffering capacity against stomach acid.
That's a great summary. The pancreas has that dual role we mentioned. Endocrine, producing hormones like insulin and glucagon that regulate blood sugar released into the blood, and its exocrine function, which is producing pancreatic juice released into the digestive tract.
Right.
That exocrine juice is this alkaline solution full of bicarbonate buffers to neutralize the stomach acid coming into the duodenum. And crucially, it's packed with potent digestive enzymes, lipase to break down fats, amylase for carbohydrates, and proteases like trypsin for proteins. It delivers all of this through the pancreatic duct, which usually joins the common bile duct right before emptying into the duodenum.
Okay. Pancreatitis, inflammation of the pancreas, is known for being excruciatingly painful. What actually causes those powerful digestive enzymes to suddenly turn against their own pancreatic tissue?
Yeah, acute pancreatitis is usually triggered either by a duct obstruction, most commonly, a gallstone migrating down and temporarily blocking the exit where the bile and pancreatic ducts meet.
Ah, the gallstone again?
Gallstone, again, very common cause. Or by direct toxic effect, most commonly from excessive alcohol consumption. Other causes exist, like high triglycerides or certain medications, but gallstones and alcohol are the big two. When the also duct gets blocked or the internal environment of the pancreas is disrupted, say by alcohol toxicity, those highly potent digestive enzymes can become prematurely activated inside the pancreas tissue itself instead of waiting until they safely reach the duodenum.
So they start digesting the pancreas.
They literally start auto-digesting the pancreatic tissue. This causes intense pain, massive inflammation, leakage of enzymes into the bloodstream, and can rapidly lead to tissue necrosis, death, and potentially trigger a systemic inflammatory response, leading to multi-organ failure. It can be very severe.
The symptoms are often described as this severe, constant abdominal pain, often in the upper abdomen that can sometimes bore straight through to the back, plus nausea, vomiting, maybe a rapid heart rate, tachycardia. And in very severe cases, you mentioned signs of internal hemorrhage might appear.
That's right. If the inflammation is severe enough to cause significant tissue death and bleeding within or behind the pancreas, in the retroperitoneal space, we might look for three fairly distinct, though uncommon, signs of this hemorrhage. There's Cullen's sign, which is bruising appearing around the belly button, periumbilical ecchymosis. There's Gray-Turner sign, which is bruising appearing over the flanks. And less commonly, Fox's sign, which is bruising over the inguinal ligament down near the groin. Seeing any of these suggests a very critical, potentially fatal progression of acute pancreatitis, indicating severe necrotizing disease.
Okay. Now, if the pancreatitis becomes chronic, maybe due to long-term heavy alcohol use or certain genetic factors, does that chronic inflammation eventually lead to failure of the endocrine function as well, affecting blood sugar?
Yes, absolutely. Chronic pancreatitis is a different process. It's more of a long, smoldering, inflammatory condition that slowly destroys the pancreatic tissue over months of years, replacing it with fibrous scar tissue. This progressive destruction damages both the exocrine function, leading to malabsorption of nutrients, fatty stools, weight loss, because digestive enzymes aren't being produced.
Right.
And eventually, it also destroys the endocrine function. The destruction of the insulin-producing beta cells within the islets of Langerhans often leads to what's called secondary diabetes, or sometimes type 3C diabetes. The patient develops diabetes specifically because their pancreas has been damaged and can no longer produce enough insulin.
Okay. Finally, let's touch on the rare but truly devastating condition, pancreatic cancer.
Yeah, pancreatic cancer remains tragically lethal. It only accounts for maybe 3% of all cancers in the U.S., but the survival rates are terribly poor, hovering around just 12.5% at 5 years after diagnosis. It's particularly dangerous because the pancreas is located deep within the abdomen, kind of hidden, and the cancer rarely produces specific symptoms until it's already quite advanced, or has perhaps metastasized, spread to other organs like the liver or lungs.
What are some of those late-stage, yet often the first manifestations?
Unexplained significant weight loss is a big one. New-onset diabetes, especially in someone older without typical risk factors, or existing diabetes suddenly becoming much harder to control. Vague abdominal or back pain is common. If the tumor happens to be located in the head of the pancreas, the part closest to the duodenum, it may compress and obstruct the common bile duct relatively early. This can lead to painless jaundice yellowing of the skin and eyes without the preceding pain you might get from a gallstone. Sometimes that jaundice is the first noticeable sign that brings someone to the doctor.
And the major risk factors.
Cigarette smoking is by far the strongest modifiable risk factor. Others include obesity, long-standing type 2 diabetes, having chronic pancreatitis, cirrhosis of the liver, and maybe infection with the stomach bacterium H. pylori. It's also slightly more common in men, particularly black men.
And treatment, when it's even possible, often requires that massive operation called the Whipple procedure.
That's right. The Whipple procedure, or pancreaticoduodenectomy, is one of the most complex abdominal operations performed. It involves removing the head of the pancreas, the gallbladder, the common bile duct, the duodenum, the first part of the small intestine, and sometimes part of the stomach. It's a huge undertaking, and it's only potentially curative for maybe 20% of patients whose tumor is found when it's still localized just to the head of the pancreas and hasn't spread or encased major blood vessels.
Only 20%.
Yeah. For the majority, unfortunately, the cancer is already too advanced for surgery by the time it's diagnosed. In those cases, treatment becomes palliative, focusing on managing symptoms like pain, relieving jaundice, often by placing a stent in the bile duct endoscopically, and maybe using chemotherapy or radiation to try and slow the cancer's growth and improve quality of life, but not usually aiming for a cure.
So when the liver is so damaged, so compromised that it can no longer support life, we reach end-stage liver disease. The final option, and really the only curative one, is a liver transplant. This is obviously a highly regulated, complex process driven fundamentally by the scarcity of donor organs.
Yeah, transplantation is the proven life-saving treatment for both irreversible acute liver failure and for patients with decompensated chronic liver diseases like cirrhosis caused by chronic hepatitis, ALD, advanced MASLD, or other conditions. Because donor organs are scarce, prioritization is absolutely key. And in the U.S. and many other places, that prioritization is determined primarily by the model of end-stage liver disease score, or MELD-C score.
Let's just deepen our understanding of the MELD score a bit. Why is that specific score the chosen metric for allocating these precious organs?
The MELD score is a numerical scale. It's calculated using specific, objective lab values that reflect the severity of the patient's liver disease and, crucially, their predicted risk of death within the next 3 months if they don't get a transplant.
Okay.
It precisely captures the failure of the liver's three main functional axes we've talked about. The score incorporates serum bilirubin, reflecting excretory failure, the INR, derived from prothrombin time, reflecting synthetic failure, and serum creatinine, reflecting kidney function.
Why kidney function?
Because advanced liver failure very often causes secondary kidney failure, a condition called hepatorenal syndrome, which carries a terrible prognosis. So, including creatinine makes the score a better predictor of short-term mortality. Essentially, a higher MELD score means a lower estimated 3-month survival without transplant, and therefore that patient gets higher priority on the waiting list for a deceased donor organ.
We discussed the liver's amazing potential for regeneration right at the beginning. How does that incredible capacity factor into the types of grafts that can actually be used in transplantation?
That regeneration factor is precisely what makes living donor liver transplantation, LDLT, possible and successful. Grafts can be, of course, a whole liver from a deceased donor, or they can be a partial liver, typically the larger right lobe taken from a healthy, compatible living donor.
And both parts grow back.
Yes. The segment removed from the donor will quickly regenerate back to near its original size in the donor, usually within months, with minimal long-term impact on their own liver function. And the partial liver transplanted into the recipient will also grow rapidly to meet the full functional demands of the recipient's body. This makes LDLT a viable and often superior option for some patients, as it avoids the potentially long and uncertain wait on the deceased donor list.
Okay. Now, the leading indication for liver transplantation in the United States today, as you mentioned, is actually alcohol-related liver disease. And this inevitably creates an ongoing controversy regarding organ allocation. This is where the really complex ethical considerations and questions of healthcare equity come to the forefront.
Yeah, this is definitely a fraught discussion, precisely because we are dealing with a life-saving but incredibly scarce resource. Traditionally, many transplant centers required a mandatory 6-month period of documented sobriety for patients with ARLD before they could even be listed for transplants.
Right, the 6-month rule.
The 6-month rule. The rationale was based on the idea that recovery requires commitment, patients needed time to establish sobriety and support systems, and that scarce organs shouldn't potentially be wasted on someone who might immediately return to drinking and damage the new liver. However, that traditional, somewhat arbitrary rule is increasingly being challenged and modified by many centers now.
Why the challenge? Is it just about pure medical need overriding other factors?
It's more about balancing that undeniable medical need with concerns about scarcity, prognosis, and these subjective, problematic notions of deservingness. The argument against rigid sobriety rules, especially for patients with acute alcohol-associated hepatitis who are often critically ill, notes that these patients frequently have the highest immediate medical need, meaning very high MELD scores and risk of imminent death.
Okay.
And importantly, studies have shown that the outcomes for carefully selected ARLD patients, particularly those transplanted early during a severe bout of alcoholic hepatitis, sometimes called early transplant, can actually be comparable to outcomes for patients transplanted for non-ARLD reasons, provided they have good psychosocial support and insight into their addiction.
So it's a complex calculation balancing medical urgency against the likelihood of long-term success and adherence to sobriety post-transplant and the support system they have. What are some other common contraindications for transplants besides active substance use?
Right. Besides active, uncontrolled substance or alcohol use disorder, other major contraindications often include having a MELD score that's considered too low, usually below 15. The thinking there is the patient isn't sick enough yet to justify the significant risks, the surgery, and lifelong immunosuppression. Also, severe, unmanaged psychosocial challenges, a documented history of consistent medical noncompliance, like not taking medications, or having active metastatic cancer outside the liver would generally preclude transplantation. The ultimate goal is always to maximize the life years saved per donated organ.
Beyond the ARLD debate specifically, the source materials you looked at point to some troubling statistical disparities in the transplant process itself, suggesting systemic equity issues.
Yes, the data does reveal some clear equity concerns within the system that need addressing. For instance, multiple statistical reviews have shown that Black patients and women are often less frequently referred to transplant centers compared to their white male counterparts, even when you try to account for similar disease severity.
Really, less referrals.
Less referrals seem to happen. Furthermore, transplant centers, historically, tend to be geographically clustered in more affluent, often predominantly white metropolitan areas. This means that patients from minority groups or lower socioeconomic backgrounds frequently have to travel significantly farther, imposing a massive financial and logistical burden on them and their families just to access evaluation and care.
That's a huge barrier.
It is. And there's also data suggesting that patients who rely on public insurance, like Medicaid, sometimes face worse post-transplant outcomes compared to those with private insurance, highlighting that the strength of the socioeconomic support system is a really significant factor in long-term survival after transplant. These are real disparities.
Okay, so assuming a patient successfully receives a transplant, the long road of post-transplant care begins. And this seems dominated by the absolute necessity of preventing the body from rejecting the new graft.
Absolutely. Preventing rejection requires a lifelong commitment to taking immunosuppression medications. Patients are typically on a cocktail of drugs, commonly including a glucocorticoid, like prednisone, especially early on, a calcineurin inhibitor, like tacrolimus or cyclosporine, and an antimetabolite, like mycophenolate mofetil.
For life.
Usually for life, although doses might be reduced over time. These drugs work by suppressing the immune system's natural tendency to recognize the transplanted liver as foreign and attack it. The downside, of course, is obvious. Deliberately suppressing the immune system makes the patient highly vulnerable to infections, bacterial, viral, fungal. And over the very long term, it also slightly increases the risk of developing certain types of cancers.
Which necessitates extreme caution in daily life, beyond just taking the pills.
Oh, completely. Lifestyle modification is mandatory. Patients must, of course, strictly avoid alcohol and any illicit drugs, as these can directly harm the new liver or interfere with medications. But they also have to adhere to pretty rigorous dietary and sanitation rules to minimize infection risk. This usually means avoiding raw or undercooked meats, eggs, and seafood, avoiding unpasteurized dairy products like raw milk or soft cheeses, and avoiding drinking water directly from natural sources like lakes or rivers, which might contain parasites or bacteria. This level of vigilance is really non-negotiable for protecting the graft and the patient's health long-term. #tagoutro.
Wow. We have completed a really comprehensive tour of the body's ultimate multitasker and its neighborhood. If you listening take away maybe 3 core concepts from this deep dive today, perhaps remember these. The liver is the primary detoxifier, chemically tagging toxins for safe disposal. It's the vital factory, synthesizing life-sustaining proteins and managing energy stores. And it's a crucial part of the digestive engine through its production of bile.
And remember, that progression of failure, chronic diseases like MSLD, ARLD, and hepatitis B/C tend to follow that slow, insidious inflammation to fibrosis to scarring continuum, eventually leading to irreversible cirrhosis and those dangerous complications like varices and hepatic encephalopathy. Whereas acute liver failure, often from something like a drug overdose, happens suddenly, dramatically, emphasizing just how quickly this vital organ's health can be compromised. The difference between recovery and irreversible failure often hinges on early recognition and intervention, especially for things we can now treat effectively, like curing viral hepatitis C or reversing early-stage fatty liver disease with lifestyle changes.
And that unique, intimate link between the liver, the gallbladder, its storage tank, and the pancreas, the enzyme supplier and buffer, means that a seemingly simple problem, like a gallstone blocking a duct, can rapidly cascade into life-threatening issues involving both the liver and the pancreas almost simultaneously. It really is one highly integrated, delicate system up there.
Absolutely. And we opened this whole discussion talking about the liver's unparalleled ability to regenerate, how it can bounce back almost completely after massive acute injury or even surgical removal of a large part.
Yeah, that was amazing.
It is amazing.
Yeah.
Yet, we spent so much time talking about how chronic, continuous injury somehow forces the liver down that path into an irreversible state of permanent fibrosis and cirrhosis.
Right, a paradox.
The paradox.
Right.
So, given its immense inherent capacity to rebuild itself, to restore its functional mass, the really critical question that researchers are still grappling with is, what specific sustained biological signal or combination of signals actually turns off that amazing regeneration switch during chronic injury and instead locks those stellate cells into a state of relentlessly producing scar tissue? Understanding that trigger, that switch from regeneration to irreversible fibrosis, is arguably the holy grail for finding ways to actually reverse cirrhosis, not just manage the complications. And that's something scientists are still racing to figure out.
A fascinating biological riddle indeed, something for you to continue exploring.
Definitely.
Thank you so much for joining us for this deep dive into the liver, gallbladder, and pancreas. We'll catch you next time on The Deep.